Good morning. Welcome to this second session focusing on the clinical management of thalassemia in the light of the TIF guidelines for transfusion-dependent and non-dependent thalassemia. I'm Anya Ardumian, recently retired consultant hematologist from North Middlesex Hospital, and I have been working as a TIF educational advisor for the last couple of years, and co-chairing is Professor John Porter, who is here, I'm sure, Professor of Hematology at University College London Hospital. Firstly, can I just say, as the talks proceed, we've got 5 15-minute talks. As the talks proceed, please think of your questions and comments. Enter them in the live Q&A section. You'll see a button at the bottom of the screen there. And if you could include the speaker for whom they're addressed, that would be really helpful. Thanks very much. So I'll hand over to John, who's going to introduce the first speaker. Thanks, John.
Thank you, Anne. So the first speaker is Ali Tahir, Professor Ali Tahir from American University in Beirut, who is well known to all of you from his extensive work on transfusion-dependent and non-transfusion-dependent thalassemia patients. He's going to talk a little bit away from his usual talks today, so it'll be interesting to see what he has to say now about renal disease in thalassemias.
Thank you very much for including me in this meeting. My second presentation is on renal complications in thalassemia, also an emerging issue. This is my disclosure once again. Also, I will be starting with a case presentation. 24-year-old female known to have hemoglobin E beta thalassemia, transfusion dependent on a monthly basis since the age of 3. She underwent splenectomy at the age of 10 due to increasing transfusion demand. This was associated with an increase in ferritin level. She is on subcutaneous desferoxamine and oral diferriprone iron chelation therapy. Presented to the thalassemia wards because of progressive worsening of generalized body swelling, frothy urine, and exertional dyspnea for the past 2 months. There was an acute decline in her renal function to a creatinine of 340 micromole per liter. Her renal function was previously normal. A renal biopsy was done showing IgA nephropathy. I just chose this as a case showing you that our patients are getting older. Our patients are having problems of renal disease. The diagnosis of IgA nephropathy, induced nephrotic syndrome, was made. She was pulsed with intravenous methylprednisolone, and then later moved into oral prednisone. Her proteinuria and renal function improved significantly. Various renal dysfunction can accompany thalassemia, and this is what we will be talking about. So after a background, I will review the renal complications in TDT, in NTDT, with some takeaway messages. So thalassemia, as I said in the previous presentation, suffer from multiple end organ damage, including heart, liver, lungs, endocrine, and this is attributed mostly due to iron overload, some due to absorption, but the majority due to transfusion. Little is known about the mechanism of kidney involvement in thalassemia. Kidney dysfunction in thalassemia includes wide spectrum of various tubular abnormalities. The data on renal disease in thalassemia is scarce, and we are getting more and more data, mostly from single centers, cross-sectional and observational. This is from a publication that I have done years ago in the American Journal Society of Nephrology, showing you the mechanisms of renal disease in thalassemia. And it affects the glomerular filtration rate, and it might be due to chronic anemia, hypoxia, iron overload, and iron chelation itself. So I will be discussing this through this presentation. So let me start with the renal complications of TDT. Renal disease has not been a major issue in the past. However, improved survival with TDT patient has led to the manifestation of renal morbidities. There are limited prospective or longitudinal studies examining renal disease in TDT. Historical data have shown that thalassemia has represented a small proportion of dialysis patients, and this can be confirmed in any thalassemia center. The emergence of aging thalassemic complication, together with the use of iron chelator medication, may shift the renal involvement from a complication of adulthood into a complication of young adults, and we should keep this in mind. So proximal tubular damage with low molecular weight proteinuria has been reported almost in every TDT patient. The urinary excretion of several markers of proximal tubular damage has been reported, including beta-2 macroglobulin, uric acid, calcium, and amino acids. Glomerular filtration rate abnormalities. At the beginning, hyperfiltration is due to anemia is common, leading to progressive with time decline in the glomerular filtration rate. Tubular interstitial injury is another damage mechanism with consequent glomerulosclerosis and kidney fibrosis due to apoptosis related to hypoxia and tubular cells. This is from one of the studies by Lai. Adults with TDT show a slow but a progressive decline in renal function. It's a 10-year follow-up of renal function in an adult TDT. So it shows you the significant decline as a result of tubular abnormality and the non-significant decline, which may be attributable due to age. So chronic anemia would lead to endothelial and epithelial damage, transduction of macromolecules, decrease of GFR. At the same time, chronic anemia would lead to decreased vascular resistance, increased renal plasma at the beginning, and increased GFR. Ultimately, tubular cell damage would lead to a decrease in GFR, and the oxidative stress lipid peroxidation would lead to cellular damage and tubular dysfunction. So an increase of GFR and the later decrease with a tubular dysfunction abnormality. Now, iron overload per se would lead also to tubular damage, glomerular sclerosis, decrease in GFR, and at the same time, iron overload would lead to cellular damage, tubular dysfunction. Not only anemia and iron overload, but also iron chelation therapy and a relative iron depletion would lead to mitochondrial dysfunction, arachidonic and arachidonic acid cascade dysfunction. This would lead to nephrotoxicity. At the same time, would lead to decreased GFR and tubular dysfunction. So anemia, hypoxia, iron overload, overchelation would lead to decreased GFR and tubular dysfunction. And as you see here, the markers of glomerular and tubular dysfunction in thalassemia patient, you would see that proteinuria remains to be the highest, but still you have increased in uric acid, increased in calcium, aminoaciduria with several other markers. The laboratory assessment is really difficult and we're not doing it at all. And I think it should be from more and more included as part of our guidelines. So renal function, whether serum creatinine, urea, electrolytes, is recommended to be monitored monthly. 24-hour urine collection for detection and estimation of creatinine, protein, and calcium. Patients on deferazirox, protein, and creatinine in a single urine sample is recommended to be evaluated monthly. So always manage the causative factor, which is anemia, iron overload, and overchelation by adequate transfusion, adequate chelation, and judicious dose adjustment according to the need. But always address any underlying renal factor disease like diabetes, hypertension, or hepatitis. One cannot but talk about the effects of chelation therapy on renal function. Causes of acute renal failure requiring dialysis have been reported after high doses of DFO. DFO use is associated with decreased GFR. Reversible dose-dependent increase in serum creatinine was observed in patients receiving deferazirox in around 38%. However, you could clearly see that there was a non-progressive change in creatinine clearance over 4.5 years of patient receiving deferazirox, non-progressive change of creatinine clearance across all ages in those receiving deferazirox. And this is just a table to show you the guidance for managing renal issues in chelation therapy. When to be cautioned, baseline tests that are needed, if increased serum creatinine, what should you do in each chelator, and if there is continued renal abnormality to discontinue. So for recommendations of iron chelation management for patients with Deferezerox who exhibit an increase in serum creatinine, the administration is usually interrupted. For chronic renal function impairment, optimization of medication through targeted describing is attempted. In patients with creatinine clearance less than 60, DFO or deferriprone is prescribed. That was in TDT. What about NTDT, and what's the difference between NTDT? As I told you in the previous lecture, NTDT patients are not transfused regularly, and we have seen more renal dysfunction in these patients. And the renal dysfunction, as you see in these two studies, which is done in my center, showed that this is associated with anemia, hemolysis, and iron overload. And the markers of renal dysfunction are also increased in patients with NTDT. 1/3 of NTDT patients have abnormality in creatinine clearance. That was really something that we have learned when we were doing the Thalassa trial and trying to find the NTDT patients. Regularly transfused patients have significantly lower creatinine clearance than those who are not regularly transfused. This is from our study where we have shown in around a cohort of 127 NTDT patients were observed over 10 years. Around 6 of the patients developed end-stage renal disease. And now probably I have 10 patients. These are all older patients, splenectomized, not transfused, not chelated. And this shows you the importance always, as we say, of revisiting our management in NTDT patients. So as a takeaway, despite expanding knowledge of renal manifestations in patients with thalassemia, it should be noted that most available studies are cross-sectional and small number of patients. Longitudinal studies investigation to look into the true incidence, mechanism, and consequences of renal abnormalities in this patient population is warranted. Investigation involving transfusion-independent patients with beta thalassemia intermedia are also called for because data in this later group is lacking. Once again, I would like to thank you and to tell you that also this is another similar to malignancy, renal disease should be revisited again. We should collect our data, have proper data in order to improve the management of our patients. Thank you.
Thank you very much, Ali, for that. I encourage people to ask questions for the joint discussion at the end of this session. So please think about questions now so that we can have an active discussion at the end. The next speaker is Nika Cappellini, also well known to most of the audience. And she's going to talk about something she's been interested in for a number of years, which is thrombosis in thalassemia, which I'm sure will cover both TDT and NTDT. So, Nika.
Good afternoon to everybody. I'd like to thank again the organizer for inviting me. I'm going to present some data on thrombosis. These are my disclosure. And it's well known that hypercoagulability and vascular disease are a source of morbidity in thalassemia. And there are many factors responsible for increased hypercoagulability. First of all, splenectomy has been shown clearly that splenectomy increases the pathologic red blood cells, either in periphery or in the bone marrow in terms of erythroblast. And these alterations are associated to increased thrombin generation and increase rigidity, deformability, and the aggregation of the red cells. But also an increase in effective erythropoiesis per se is responsible of these pathologic erythroid cells. Moreover, iron overload, which is part of the thalassemia clinical phenotype, is responsible for endothelial injury with a high expression of adhesion molecule and tissue factors. And moreover, splenectomy is responsible of increased number of platelets, but not only, they present also a chronic activation and an increased adhesion and aggregation. All these together are responsible for thrombosis. Moreover, due to liver disease, we have a decreased protein C and protein S synthesis. So this cartoon summarizes more or less what I tried to explain in the previous scheme. So the adhesion is responsible of thrombi formation, but also the thrombin generation is increased due to an increased phosphatidylserine exposure of damaged erythrocytes and erythroblasts. We notice, but even early paper observed that splenectomy is associated to several adverse events, including thromboembolic events. But few studies were available on this subject. And almost 20 years ago, when my team started to follow non-transfusion dependent thalassemia patients, we noticed that those non-transfusion dependent thalassemia patients splenectomized had high risk of thrombosis compared similar patient splenectomized but transfused. So we thought that the major difference between the two groups was the number of circulating erythroblasts. So we purified the erythroblast from different patients, splenectomized thalassemia intermedia, non-splenectomized thalassemia intermedia, splenectomized control, and we generate a test for checking the thrombin generation as it is done for platelets. And this figure represents an example, a representative example of this erythroblast in test for generating a thrombopoietin. And you can see that there was a significant difference between the splenectomized thalassemia intermedia patients and non-splenectomized. So higher rates of procoagulant RBC and activated platelets in splenectomized patients are definitely playing a major role in increasing the coagulability in such patients. And from the optimal care study, we try to understand if this observation was real. And we selected out of 584 patients, 325 who were splenectomized. And we look at the comorbidities, and definitely it came out that splenectomy was independently associated with an increased risk of most disease-related complications, but for sure to increase thrombotic events. Based on that, we actually did a survey in collaboration with Professor Taher to check thrombotic events in a large cohort of thalassemia patients from Middle East and Italy. We got information for 8,860 patients, 6,600 were thalassemia major and 2,200 thalassemia intermediate. And thrombotic events were detected in 146 patients, of whom 61 were thalassemia major and 85 thalassemia intermediate, which means 4% of thalassemia intermediate patients had thrombotic event. And the risk factors for developing thrombosis in thalassemia intermediate were age over 20 years, previous thrombotic events, family history, but definitely splenectomy. And on the right side of the slide, you can see the type of events: venous thrombosis, but also some stroke, DVT, pulmonary hypertension, and so on. So starting from that, some authors look to the damage in the brain, and this study on 30 patients who underwent brain MRI and PET scanning showed that 60% of these patients had abnormal MRI finding, 63% had abnormal PET finding, and 86% had abnormal MRI and PET or both. So this means that we may have asymptomatic brain damage in splenectomized adult patients with non-transfusion dependent thalassemia, and other cerebrovascular complications were observed in splenectomized patients, such as large vessel stenosis, decreased neuronal function. And this has been a consistent observation, especially in splenectomized patients, and several reports from 1999, but still there are papers ongoing confirm this increased risk with abnormal brain, with abnormality in brain MRI and PET. Again, utilizing the study of the optimal care, we try to identify which factor may be predictive for thrombosis. And from the optimal care, we identify 3 groups of patients. Group 1 included splenectomized patients with documented thromboembolic events. Group 2 was including age and sex match splenectomized patients without thromboembolic event. And group 3, age and sex matched non-splenectomized patients without thromboembolic events. And doing a comparative analysis among these 3 groups, we found that the mean nucleated red blood cell count was higher in group 1 compared to group 2 and 3, which means higher in splenectomized patients with thrombotic events, but also the platelet counts, as well as the presence of pulmonary hypertension. And a multivariate analysis actually showed that nucleated red blood cells were statistically significant as a risk factor, platelet counts, pulmonary hypertension less, but transfusion naivety was also a factor contributing to the risk of thrombosis. But this goes probably associated to the increased number of nucleated red cells. So group 1, patients splenectomized with thrombotic event had significantly higher nucleated red blood cell, platelets, risk of pulmonary hypertension, and mostly were not transfused. And in terms of transfusion, actually, it came out that transfusion therapy was protective for thrombosis, extramedullary hematopoiesis, masses, and other comorbidities. Although, of course, transfusion therapy is associated with an increased risk of endocrinopathy, mainly due to iron overload. So the asymptomatic brain damage was already mentioned, and the risk is associated with age and transfusion naivety. What is interesting to know is that the time to thrombosis since splenectomy is variable, but actually we notice that the median time to thrombosis following splenectomy was 8 years, with the range from 1 to 33 years, which means that thrombotic event in splenectomized patients may occur at any time, but definitely was shorter in patients with a very high nucleated red blood cell count, higher than 3,000, and a platelet count higher of 5,000. In TDT patients with the advancing age, splenectomy, anemia, and iron overload, there was also an increase of risk for pulmonary hypertension. And several factors can be identified for recognizing patients susceptible to pulmonary hypertension. Definitely splenectomy, history of thromboembolic events, high number of nucleated red cells, naivety to transfusion, naivety to chelation, and also naivety to hydroxyurea, because in this study were included also some patients on hydroxyurea. Thus, we may say that non-transfusion dependent thalassemia patients should be considered at higher risk for thrombosis or for cerebrovascular disease than healthy individuals. And here are listed the patient characteristic, the blood-related parameters that I already mentioned, and the medical history. We try to generate a thrombosis risk scoring to facilitate the identification of patients at risk, giving a score to several items, such as age more than 35, hemoglobin level less than 9, serum ferritin more than 1,000, not regularly transfused, and splenectomized. And according to the value, the patients could be considered at a low risk if they have a score less than 9.5, intermediate risk 9.5 to 13.5, high risk if a score higher than 13.5. What about anticoagulation? Still, we are repeating and repeating that we need to have proper clinical prospective trial on anticoagulation, but that's not easy. And still we have few data, case report, but we miss prospective clinical trial on prevention with anticoagulation. And I just want to end with this table were published in the recent review in New England Journal of Medicine, where we suggest how to monitor and how to manage or prevent thrombosis and vascular events and pulmonary hypertension. I'm not going into details, but just for thrombosis and vascular event, preventive anticoagulant therapy should be performed per local standard based on thrombotic risk. Aspirin in splenectomized patient is advisable for platelet count above 500,000. lower prevalence of primary and secondary vascular event in patients with non-transfusion dependent patients receiving a transfusion has been documented. So maybe transfusion in some circumstances may be a treatment or to prevent thrombotic events, especially in occasion of surgery, infection, and so on. And for pulmonary hypertension, we are following the criteria used to define pulmonary hypertension and for the proper treatment. With that, I thank you, and I will be available for taking any question.
Thank you very much, Professor Capellini, for that excellent, interesting talk. Much to discuss there. No questions are coming up, but I've certainly hatched a few during that presentation, so we'll have a discussion later on. Thanks. It's my pleasure next to introduce my colleague Perla Eleftheriou, who is a consultant hematologist, honorary senior lecturer, and the lead for red cell hematology at University College. Talk about what I think has been a rather neglected specialty area, which is pain in thalassemia. Thank you, Perla. I think
Good afternoon, everyone, and thank you very much for inviting me to talk at this Thalassemia International Federation conference. And I wish next time we will be meeting in person again. I'm Perla Eleftheriou, hematology consultant at University College Hospital in London, in the UK. I'll be now sharing my screen. So generally speaking, pain is much commoner than we think. It can be complex and multifactorial, and physical and psychological factors often interact as causes of pain. In the States, about a third of patients over the age of 20 complained of pain in the 4 weeks leading to the standardized questionnaire that they had to fill in for this study. So much commoner, generally speaking, in the general non-thalassemia population as it is than what we think. Now, talking about the specifics in our thalassemia population, pain has a major impact on quality of life. It can be unpredictable, it can be severe and acute, but it can also be chronic and low grade and lingering in the background. Often, pain is a cause of hospital admissions, and often also leads to poor compliance with treatments such as iron chelation. Generally speaking, pain in thalassemia is suboptimally managed, as often the cause is not recognized or the cause is multifactorial. In the last decade, prognosis has improved in thalassemia, as we know, and therefore the pain has become an increasing growing problem. It has become the major cause, one of the major causes of comorbidities in thalassemia, and the age is the strongest predictor of frequency and severity of pain. But there is indeed still knowledge gap in the causes and predicting factors of pain in thalassemia. However, it is well recognized that usually it is multifactorial. So conditions or problems such as osteoporosis, extramedullary hematopoiesis, early degenerative disease, anemia-related bone disease, vitamin D deficiency are usually the predominant causes of pain in thalassemia, and this can be in isolation or in combination. So in other words, a lot of those can be coexisting in our patients. Of course, we mustn't forget that the pain can be influenced by emotional, psychological status, and this should always be taken in consideration when we evaluate our patients for pain. And of course, we have to make sure that we always think about non-thalassemia related pathologies which might be contributing to the pain. So is it even an issue? Should we be talking about it? Absolutely, not just from our own experience with our own patients where we look after them, but also looking at the literature. There is convincing data that indeed pain is something that we need to be talking about, and even more than ever before, as our thalassemia patients live longer, thanks to the medical advances in the field of thalassemia. So the pain increases with age, and it increases in both severity and frequency. And 56%, so more than half of the patients over 35 have pain, according to this study, which was published in 2013, and we'll go into a little bit more detail about it in the next few slides. So if we talk about the main factors which contribute to pain in thalassemia, anemia to start with, the bone marrow expands as the hemoglobin drops, and the pain commonly manifests itself in the back and lumbar spine, and it's usually worse in the week before the transfusion. It's often described as throbbing in nature, and generally speaking settles after the patient had the transfusion. The presence of frequent, though, and persistent pain should alert to extramedullary hematopoiesis in both thalassemia, in both transfusion-dependent as well as non-transfusion-dependent thalassemia patients, and we do see it much more frequently in the latter group of patients. So this study, thank you very much, Dr. Shah, for sharing her slides. This study was done at the Whittington Hospital, where Dr. Shah practices. 106 records were reviewed for history of back or bone, generally bone pain in thalassemia patients. 47 out of those 106 had any form of imaging or relevant imaging undertaken. And the imaging was scored using a standard methodology, and essentially 60% of those older than 40 years had evidence of degenerative diseases, but also a respectable proportion of more than 30% of those less than 35 years of age, so at young ages essentially, had evidence of degenerative changes. Treatments that patients had, about a third were receiving regular physiotherapy, 19% had spinal injections, 9% had surgical interventions. There was no correlation with osteoporosis in this study, and there was multi-level degenerative disc disease present in 96% of patients who had undergone imaging. Going on to the next important cause of pain is vitamin D deficiency. Most patients are deficient if they're not on supplementation. And what vitamin D deficiency does is pain in bones and muscles, muscle cramps, fatigue, and ultimately osteomalacia, resulting in bone complications if left untreated. So supplementation of vitamin D should be long-term, generally 20,000 units weekly or fortnightly, and the target levels should be what the normal range is for your center, but we recommend levels of above 50. In some patients with severe iron overload, desferal administration causes severe bone pain. We see that from time to time, although not very common. It is difficult to manage, especially if patients cannot switch to a different iron chelation. And we can see that both with IV and subcut administration, but it's probably a bit more common and more severe within the intravenous desferal administration route. Absolutely important to continue support and encourage your patient and through this, and especially if there are no alternative routes for chelation administration, and to ensure that they receive the appropriate psychological support as well. Generally speaking, the pain related to the iron overload or even to the desferal reduces as the iron burden comes down. Diferriprone in itself can cause significant joint pains in some patients, and deferrasirox can cause abdominal pain in some patients due to either gastritis or gastric ulceration, side effects which are not, or complications which are not very common, however can occur, but also some patients can develop non-significant, non-specific to any pathology, intermittent abdominal cramps. So going into a little bit more detail about this big study, which was presented at the published at the British Journal of Hematology in 2013, pain in thalassemia, the effects of age on pain, frequency and severity. who participated in this study, 252 patients with various thalassemia genotypes, ages 12 to 71, so transfused and non-transfused, but the majority were transfusion-dependent thalassemia patients. The questions asked were how common the pain is, how severe it is, how frequent it is, where it is predominantly, what the cause of pain is, and how it is managed. 64% of the patients reported experiencing pain in the last 4 weeks prior to the questionnaire. 73% of the participants older than 20 years reported pain in the last 4 weeks, versus, remember, the 20% in the non-thalassemia US population, so significantly high proportion. More than a third of the patients reported pain in the last 7 days even, and more than half of those older than 35 years reported pain in the last 7 days. It was very obvious looking at the age groups with patients participating in the study that the pain significantly increases with age. In terms of duration, you can see that a quarter had the pain for more than 5 years, and another big proportion, so 20%, for a year. So essentially, we're talking about the majority of our patients suffer from chronic pain, which lasts long. In terms of the causality of the pain, the following factors were looked at to see whether any of those make a difference: so hemoglobin level, bone density, fracture history, iron overload, and chelation agents. And this study found no correlation or between pain and any of those factors. In terms of management, 63% used pain medications on a regular basis, the majority non-steroidal anti-inflammatories, followed by paracetamol, and a small proportion, but not negligible, are using chronic opioids. 47%, so nearly half of the patients reported decreased pain with blood transfusions, so an intermittent type of pattern with peaks of pain prior to transfusion and a reduction of the pain intensity post-transfusions, which is something that we know very well from our practice as well. And 43% reported decreased pain with rest. So the summary: pain is common. The frequency and severity increase with age, is chronic. The primary site is the back, and the etiology remains elusive. I'm moving on to show you our study, which was done in 2017 at UCLH in our attempt to explore a little bit further the pain in our thalassemia cohort. So the aims and objectives were to look at the prevalence and characteristics of chronic pain in thalassemia, the impact on the patient's lifestyle, and look at the musculoskeletal changes of patients with pain, which could correlate with the site of the pain. So we used a standardized questionnaire, which was distributed to our patients when they attended their regular transfusion sessions in 2015, and we received 41 questionnaires back and analyzed them. Back, knees, most common sites of pain, and you can see here the differentiation between the different age groups that shows the patients above the age of 40 are significantly more affected by pain compared to the younger population. So all the patients above the age of 48 had significant and frequent pain. And if you look though at the younger cohorts, still a very significant proportion is affected despite their young age. You can see that 19 to 24, a third of the patients had chronic pain, and more than, so 75%, so 3/4 of our younger adults, so 25 to 36, had significant pain. So exploring this further and differentiating the characteristics of the pain into two groups, so less than 40 years and above 40 years of age, you can see that almost all the more than 40 years old patients had pain, as opposed to about 68% of those less than 40 years. Still a big proportion of those patients had significant regular pain. Pain worsens with age, yes, so 80%. of the older than 40 years reported that the intensity and frequency of the pain has increased as the age advances. And in terms of the average severity of the pain, you can see that it's much more intense in the older population. And in terms of the frequency, so pain frequency per month, or pain occurrence per month, in the older population, pain happens daily in 40% of the patients, and 1 to 5 times a month in about 65% of the patients. Paracetamol is the most, as well as non-steroidal anti-inflammatory drugs, are the most often used analgesia agents in our groups as well, similar to what the US study has showed, but still a significant proportion, although much less, uses opioids. And in terms of the relationship with transfusion, so 78% of our patients reported changes in the pain in relation to their transfusion timing. Almost all of them reported improvement following the transfusion, which occurs 1 to 72 hours after the transfusion, and 84% reported worsening of the pain before the transfusion, mostly 1 to 7 days before. 21 patients with back pain had imaging, which included the spinal column, and the majority had, regardless of the age, even the younger patients, younger than 40 years of age, had significant disc degenerative changes. 78% reported that this has a huge impact on their quality of life and stops them from doing things they enjoy on a daily basis, but only a third visited their GP specifically due to pain. So another important study to look at, which was one of the most recent ones, done by and led by Shruti Kakar in India, which I had some input in: prevalence, severity, and determinants of pain in thalassemia. The cohort was everybody enrolled was everybody with thalassemia older than 10 years of age. So this study included much younger patients than our study and than the American study. The exclusion criteria was presence of cause of pain other than thalassemia, and the pain assessment was done during using the brief pain inventory. And the next few slides will summarize what we saw. So the prevalence of pain significantly increases as the patient's age, as you can see here. So, and also a significantly higher percentage of females reported pain during the last week and the last 4 weeks as compared to males. So the last 4 weeks leading to the questionnaire. But you can see that looking at the age cohorts on the right hand side, that even obviously the majority of the patients included in this study were pediatric patients, but even so, significant proportion of those patients, if you look at the bars, reported pain. So even the young ones, so if we take, for example, the 10 to 15 years old group, the total number of patients was 68, and about 40 patients out of these 68 reported pain. Pain was found to be aggravated by increased physical activity, for example, climbing stairs, etc., and predominantly involved the back and the calves, and the type of pain was aching and tiring. Factors associated with increased prevalence of pain through the data collected from this study: female gender, residing in urban areas, thalassemia in siblings, and employment. There was no significant relation of pain to the mean hemoglobin, nutritional status, iron chelation, or bone mass density, or any other endocrine abnormalities, but there was significant correlation seen with the serum ferritin levels, with the liver iron concentration, and vitamin D levels, which is interesting. as one would expect. So this table summarizes other studies assessing pain. There aren't many studies looking at pain in thalassemia, and I guess this is one of the reasons we're talking about pain in thalassemia in this conference, because we want to highlight it more than ever before. So you can see from the studies that there are 5 big studies involving more than 200 patients, and the most recent Indian study involved 100 patients, and the majority of the studies which were already published looked at the adult population, as opposed to the Indian study, which looked at the more at the pediatric population. But essentially you can see that in terms of risk factors, we are still a little bit in the dark as to whether there are any concrete and sort of well-established risk factors to help us predict pain in thalassemia. But there is pretty much consensus that the low hemoglobin or the pre-transfusion low hemoglobin plays a role, and perhaps the iron overload and the historic iron burden. So the care of patients with pain have to be very much tailored to their individual characteristics. So recognizing that pain is a complex and multifactorial yet very important issue in thalassemia, the approach should be individualized. The assessment and management should be tailored to the problems of each individual patient, and specific targets should be put in place to manage those specific problems. But good and ongoing communication with the patient, as well as input from the hematologists, psychologists, and pain teams, are of paramount significance. In terms of analgesia, anything can be used according again to what is going on with the patient, starting from simple oral analgesia, moderate opioids, strong opioids, but also not to forget the non-opioid drugs, because in a lot of patients there is a significant neuropathic component in how they perceive the pain. Other strategies for pain management: switching to a different analgesia medication, discussing and educating the patient about the difference between acute and chronic pain and how this can be differently managed. And of course, from our point of view, the main clinicians or healthcare professionals looking after these patients should be thinking about adjusting transfusion programs to increase pre-transfusion hemoglobins, or introducing other medications such as hydroxyurea or other innovative drugs to change the disease phenotype. Needless to say how important the psychology input is in terms of pain management technique education, cognitive behavior therapy, and distraction techniques. But it's important to involve the psychologists upfront and early on, rather than later when the problem escalates and becomes much more complex. It's important for the patient, as well as the healthcare professionals, the hematologists looking after these patients, to be supported throughout this and upfront. So to conclude, pain is an emerging complication in thalassemia. It's found to be associated perhaps with higher iron overload and low vitamin D, as well as low pre-transfusion hemoglobins. Thalassemia patients seem to develop earlier compared to the age-matched population, spinal degenerative disease. Pain significantly influences mood, sleep, walking ability, quality of life. Patients with pain need regular assessment and targeted management. And indeed, further work into the causality of the pain is needed, especially in relation to the skeletal findings and the relation of those findings to iron deposition and other parameters such as endocrine profile and hemoglobin levels. We need to make time dedicated for pain education and review of pain during the consultations with our patients. I want to thank all my patients and all my colleagues and collaborators in London and in India and elsewhere, and the Red Cell network that I belong to. Thank you all very much for listening.
Thank you, Perla. Very interesting area, and as I say, killer 2 probably less discussed than we thought to have been. I'm pleased to introduce the next speaker, Professor Nikos Skordis, who's a paediatric endocrinologist and the Professor of Paediatrics at the School of Medicine in the University of Nicosia, who's known for his long clinical service in the field and also for his many publications about bone disorders and growth and other endocrine complications. And he's going to talk today about pregnancy. Thank you.
Good morning, everybody, or good afternoon for some people. This is a live transmission. It's not recorded. So it's going to be on fertility and pregnancy in thalassemia. It's a field that has been in the research area over the past 30 years, and I would like to thank the organizers for inviting me again to talk about this. This is an old work that we did some years ago, but the numbers, of course, they're increased. But what I would like you to focus on is that some women that had primary amenorrhea and secondary amenorrhea, because of hypogonadism, they were able to become pregnant and deliver healthy babies. Now, following these publications, some other papers appeared in the literature, as you can see here. And of course, the conclusions and the message of all these publications are that with proper care and guidance among women with thalassemia, women can deliver pregnancy in these women is practical with successful outcome, no complications regarding heart. However, there is a higher incidence of IUGR. IUGR stands for intrauterine growth retardation and preterm labor in some publications. Provided that a multidisciplinary team is available, pregnancy is possible, safe with a favorable outcome. And women who have amenorrhea, fertility is successful. So pregnancy is feasible and safe in women with thalassemia, provided they have a normal resting cardiac performance and optimized iron overload. Of course, in specialized centers, this that we have to highlight under a multidisciplinary team. Now, having all these pregnancies, just summarizing all the papers, in 37.3 women, 426 pregnancies, most of them resulted in full-term babies. There was a small number of preterm and abortions, as seen in the general population. Of course, ferritin is increased after pregnancy, and this is because of the discontinuation of the chelation therapy. This is the work that we did on heart performance before pregnancy at first, second, and third trimester. No significant complication. There were some changes, but as expected, due to the, as seen in the third trimester of pregnancy. So the conclusion, pregnancy is safe for cardiac function, provided these women have started early on proper treatment and have a normal resting cardiac performance. Chelation therapy before pregnancy is very important so that the ferritin level is optimal. Now, in summary, pregnancies among women with thalassemia are feasible and safe. They have a successful outcome, no severe complications, no deleterious effects of pregnancy on the course of their disease. Spontaneous fertility can occur in well-chelated and transfused patients women with hypogonadism, they preserve their ovarian function and they are able to conceive, of course, following a closely monitored hormonal induction of ovulation. Normal resting cardiac performance and optimized iron overload is crucial. Minimal risk for preterm labor and growth restriction of the baby. And of course, all the papers they highlight that these women have to be under the care of a multidisciplinary team. So we have a maestro here who is the hematologist, and all the other specialties, the gynecologists, the endocrinologists, the cardiologists, that they are involved in the medical care of these women. We have happy families, and this is the woman in thalassemia in Limassol with triplets. Of course, she had a very hard time during her pregnancy, but thank God everything went smoothly afterwards. So there are some issues that we discussed regarding the medical history. Emotional dilemmas often pose some problems in our decisions. Legal issues also are discussed, and ethical issues as well. This paper appeared in 2017, highlighting the increased risk of obstetric and perinatal complications in women. Preconceptual problems that include anemia, iron overload, and cardiac dysfunction, thrombosis, alloimmunization infections, and endocrine and bone disorders, they could influence the outcome of the pregnancy. And of course, there are some unanswered questions regarding the safety of iron chelation therapy during pregnancy and any deleterious effect of pregnancy on the long-term health of women, especially when maternal complications occur. These questions, they remain with no answer. Now, let's see now who are eligible for pregnancy, what has to be done before. Of course, heart, liver, vessels, endocrine, thyroid, and calcium, pancreas with the glucose homeostasis, check for viral infections, and of course, very importantly, the iron status. Any woman who is seeking pregnancy, she could optimize chelation therapy, have a normal cardiac function and liver function as well, check the thyroid, check for viral infections, optimize diabetes control, review the medications that she is receiving, screen for acquired antibodies, red cell antibodies, because there is a risk of hemolytic disease, check for the partner for hemoglobinopathy, and of course, if necessary, arrange a genetic counseling. Before pregnancy, emphasize the supplementation of folic acid, stop the chelation therapy and vitamin D, stop ACE inhibitors. The woman with the glucose homeostasis issue can continue metformin, but many of them, they require insulin, which is more safe during pregnancy. Of course, we stop biphosphonates and give calcium and vitamin D as in all other pregnancies. During pregnancy, try to maintain the hemoglobin at the level of 10 to allow the normal fetal growth with frequent and low volume blood transfusion, ultrasound periodically just to monitor the fetal growth, check the heart, check the blood sugar, and of course, again, approach by all specialists who are involved in the medical care of women with thalassemia. This is very important. Another paper, most recently, 2019, women with non-transfusion dependent thalassemia intermediate, who have never been previously transfused or received only minimal transfusions, they are at risk of severe alloimmune anemia if blood transfusions are required during pregnancy. This we need to have in mind. Since pregnancy increases the risk of thrombosis, as Dr. Capellini mentioned before, this is another issue that we need to consider. And of course, nowadays chelators are not recommended but in case that the ferritin level is increased, especially during the last trimester of pregnancy, consider restarting the chelation therapy. So the key points is that the desire of these women with thalassemia to achieve a motherhood should be recognized, respected, and approached with special caution and sensitivity by all physicians who are involved in the medical care of these women. Of course, there are some problems, medical problems, legal issues, ethical issues that they have to be faced and try to find the solution. And we have to ensure that the best outcome for the mother and the baby. So we have to balance between the quality of life of these women and their desire of becoming pregnant. One issue is the induction of ovulation that carries some risk. This induction of ovulation takes place in women with amenorrhea, or women who fail to conceive, or women that they will have a planned pregnancy. One of the problems that we face sometimes is the ovarian hyperstimulation syndrome. It's a severe situation that presents clinically with abdominal swelling, with ascites, with thrombosis, with kidney failure, with severe pain. And these women, they require hospitalization to be given IV fluids and, of course, to give the medicine to ease the symptoms and reduce the activity of the ovary. So we need to monitor the ovarian function by measuring the estradiol level and ultrasound to reduce the risk of this unwanted syndrome, this ovarian hyperstimulation syndrome. So this we need to have in mind when we have a woman with thalassemia who is undergoing ovarian stimulation for pregnancy. Ovarian reserve is another issue. This is the capacity of the ovary to provide eggs that are capable of fertilization. And we see that ovarian reserve decreases with years. We have some markers of measuring ovarian reserve, and this is based on indirect measures of the antral follicles, of the pool of the antral follicles, and the hormone which is the AMH. This is anti-Müllerian hormone. And low ovarian reserve is considered predictive for low chances for pregnancy. So it's good to have an index of the ovarian reserve of any woman who is seeking pregnancy. One marker is the antral follicle count. This is visualized with the ultrasound. Of course, it declines with age, and it reflects, it is the pool of the primordial follicles that they will eventually become follicles with stimulation. This declines with age. Another marker is the anti-Müllerian hormone. This is secreted by the preantral and early antral follicles. It is a marker that changes, of course, with age. And again, this decreases with age. And the data that we have in thalassemia is that thalassemics, they have a lower AFC that decreases with age. They have a lower AMH, it decreases with age. And then if we compare this with the iron status, we see that there is a correlation, a negative correlation. The higher the ferritin, the low AMH. So optimizing chelation therapy is very important. So the take-home message is that improved fertility with optimized iron overload, improvement of life expectancy and quality of life in women with thalassemia increases their potential for reproduction. Their desire to become pregnant should be respected. Women with thalassemia require a careful management before pregnancy, having all these issues in mind, and of course, approach and care to be given by the team. Now, how about the men now? The men are fertile, more or less most of the men who have either normal gonadal function or hypogonadism, and they were treated early in life in their early 20s for hypogonadism, not very late. They were able to become fathers. We have a protocol for induction of spermatogenesis, and I'm again highlighting the fact that this has to be done in their early 20s and not later. So we measure the baseline testosterone, we give a combined HCG and HMG for a year. We check the semen, and then if spermatogenesis is satisfactory, we save the semen for future IVF. We have 3 groups of patients. Some do not respond at all. Some they have a good response, and some they have an intermediate response. Those who did not respond, they were the ones with the higher ferritin levels, and they were the ones who started therapy for induction of spermatogenesis very late in life, after the age of 30. So if spermatogenesis is to be achieved, then this has to be started in their early 20s. Remember that only 1 sperm is sufficient. This can be taken from ejaculated or spermatozoa that have been frozen or from testicular biopsy. The question, though, remains whether there is a damage in the DNA of the sperm in males with thalassemia, whether the DNA is fragmented. 2 papers back 20 years ago, there is increase in sperm DNA damage, and this is because of the iron overload. So this finding, the conclusion of this work is that this finding has important implications in assisted reproductive technology techniques, where there is increased risk of transmitting this defective DNA to the offspring, because in this case, the egg is unable to defend itself. And another work again on the DNA damage, and this highlights the side effects of desferrioxamine. However, from the experience that we have, we didn't have any issue regarding the outcome of the babies of the fathers. Back in 2010, our friend Kalisteni Farmakis highlights, of course, the importance of optimizing chelation therapy, and these are the results. Some of the males discontinued testosterone therapy and 1 became father, and some of the females that they were hypogonadal, they were able to conceive. So keeping the ferritin at the lowest acceptable level is ideal. So just what is recommended for a woman who is seeking pregnancy: if the partner is non-heterozygote and the woman has normal menstrual function, then spontaneous pregnancy can be achieved. However, when the woman presents with amenorrhea or she has failure to conceive, then assisted reproduction is recommended. When the partner is heterozygote, of course, they can proceed to the pre-implantation diagnosis. And when the partner is homozygote, the options are gamete donor, either egg or sperm, or adoption. However, we have, when the partner is homozygote, this is a picture of our late Yoda that she passed away due to COVID. We respect their desire, and they had this boy who is now a student. You can see the picture on the left. So respect the desire of women with thalassemia. Thank you very much.
Professor Scores. And our final speaker for this morning's session is my long-standing colleague, John Porter, who's very well known to everyone in this audience for his decades of work on iron metabolism and iron chelation. And today he's going to be talking about emergency management. Thank you, John.
Hello, my name is Professor John Porter from University College London. I've been asked to talk about emergency management of thalassemia. We produced a booklet for TIF about this, which I think has some pointers about how to approach a patient who's unwell. I think what I'm planning to do is just go through some of the pointers there and how we can think about it. There's a simple overview of thalassemia, which most of you know about already, of course. We're going to look at what we should ask, particularly in the history. We're going to talk about what particularly we should look at in the physical examination, and then we're going to do a problem-oriented approach to the management of those issues. So in the history, there are some things that might be particularly worth focusing in on. The presence or absence of a spleen is a key thing, and in relation to that, the vaccination history and what prevention has been done for infections in that context. Because of many patients getting regular transfusions, we have to think about the risk of hepatitis. It's much less common now in the UK, but in many parts of the world, it's still an active issue. We want to know what the current chelation is, and obviously, if people are on chelation, we need the details. We need the granularity on that. We need to know the doses that are being taken, how often it's been taken. We know, for example, that some infections are much commoner in iron overload. The two major culprits are Klebsiella, which we see quite a lot of, and Yersinia is another classic one, which can be worse with iron overload and also actually with chelation as well, with Desfro. Has the patient been treated for hepatitis? Are they being treated for hepatitis? Is there a history of hepatitis, particularly if they're jaundice? Is the patient on anticoagulants? Lots of patients are on anticoagulants, and again, the details of that are really important. And have they had any problems with heart rhythms or heart failure in the past, and what medication are they taking for that? We need to understand what the current status for iron overload is. If the patient turns up at your own A&E department, you've probably got all the details. You've got the pattern, the trajectory, the direction of travel of serum ferritin. But if they're not your patient and they've just turned up at your hospital for various reasons, then you need to sometimes work quite hard to get the history. And of course, the patient themselves, if that's you and the audience listening, how you provide that information is really helpful to the doctors and nurses looking after you to make the right decisions. We need to know the surgical history. Has the gallbladder been removed? Has the spleen been removed? Is there a history of fractures? And I think to suggest osteoporosis, all these things. For example, with chest pain, I've found over the years one of the commonest causes of chest pain is a rib microfracture, and you can go in the wrong direction completely if you don't consider that. When we do physical examination of thalassemia patients, we need to look at the skin. Is there a tanned discoloration, a darkening of the skin from iron overload? We examine for the liver and spleen. The cardiovascular system, we're thinking particularly about the rhythm of the heart and whether there's any signs of heart failure. Remember that if you're getting right-sided heart failure, expansion of the liver capsule, back pressure onto the liver can cause abdominal pain. And I've seen cases where a patient has been diagnosed as having an acute abdomen, a problem with appendicitis, for example, when actually the primary problem is failure of the heart, stretching the capsule of the liver. We need to think about the nervous system and brain abscesses and stroke. We've seen that over the years with thalassemia. And of course, vision. We need to think about whether there's any problems from vision. We know that chelation can cause problems, particularly Desfro, but we also know that thalassemia itself can affect the eyesight. So when we think about problem management, we can think about sepsis, anemia, shortness of breath, edema, chest pain. So the way this is set out allows the clinician or the tending team to focus in on a particular problem to see advice on each of those. There's a little pathway for each one of those. So we need to think about possible causes and what investigations we're going to do here with sepsis as a guideline for how we can go about this. I've already mentioned that Klebsiella and Yersinia are two of the things to look out for. We're not going to have time to go through in great detail, but it's all there in the book. Where is the infection coming from? If someone's got a fever, is it the renal tract? We're seeing increasingly in older patients stones. So sometimes they can get kidney stones and they've been without symptoms up until that point, but then the stone gets lodged at some point in the renal tract and can be the source of infection. So if you find someone's got a urinary tract infection, for example, with Klebsiella, then you need to think about whether there is a stone there which is acting as a focus for that infection. And we often find that, and increasingly in older patients as well. Respiratory tract, obviously, is a common source for infection, and we would look at that and get a proper history and examination. The abdomen, as I've said already, you can get fooled with that when the heart is failing, causing pressure on the liver, but gallstones are very common in thalassemia patients, so we would think about that top line. We've seen infections. Obviously, if you've got a line in, some patients have indwelling lines for reasons of continuous chelation. Obviously, that would be a source potentially of infection, and we can get. We've seen cerebral abscesses. You've seen myocarditis, endocarditis, and the teeth, very important. So we work as well as we can do with our dental department, because having the teeth regularly reviewed, not as a source of infection, is really important. So in the book, you've got an algorithm here to help you, guide you through the diagnosis and the identification of the source of infection. Not going to have time to go through that completely. Let's think about shortness of breath. Now, shortness of breath is really important physical sign. One of the important ones to think about is a blood clot or a series of very small blood clots passing from some part in the body into the lungs. And we need to think about that as being an important cause to exclude. Congestive heart failure with myocarditis or iron-related cardiomyopathy, iron getting into the heart and causing the heart to fail, is obviously one of the major things we need to think about. We need to think about abnormalities of the rhythm of the heart, and it's very simply identified if the rhythm is abnormal, but sometimes people go in and out of abnormal rhythms, so you've got to watch out for that. Pulmonary hypertension, where the blood pressure on the right side of the body goes up because the stiffness of the vasculature of the lungs is abnormal, or the right side of the heart is failing for other reasons. Very important thing to look out for in thalassemia, which is commoner than the general population. Microfractures, small fractures in some of the bones can present as other problems. So particularly in the ribs, for example, as I've already said, can cause pain in the chest. Pericarditis is relatively rare now compared with how it used to be, but still you can get inflammation in the sac around the heart. And of course, anemia is an important cause of increasing shortness of breath. So again, I'll just whistle through those. It's all here in the book. Heart failure, very important thing to look for and to think about, and I've already covered those. Chest pain, less of a presenting problem in thalassemia than some other conditions, but obviously chest pain can be brought on by pulmonary embolism, rib microfracture, pericarditis, congestive heart failure, or coronary artery syndrome. So all those things, it's all covered in the book. Then we think about abdominal pain. I've already touched on these, and they're well talked about in the book. Rarer causes of mesenteric infarction, haven't seen a lot of that. Renal stones are increasingly common, we see quite a lot of that. Peritonitis, gastroenteritis, and even classic acute appendicitis we see. Headaches are common, and we need to make the right decisions in relation to causes of headaches, and these problems are identified in the book, and again, just help guide you through how to investigate it. Meningitis, sinusitis, otitis media, extramedullary masses where the bone marrow expands in parts of the cranium, and that's discussed in some detail. And there's a nice algorithm there about how to investigate headaches in thalassemia patients. Back pain is a real issue, both in the outpatients and the A&E setting, and the book goes through that and how to think about causes of back pain. Not straightforward. Sometimes it's degenerative, and sometimes it's the intervertebral disc which are causing the problem. So to conclude, in that 15 minutes, I've whistled through the book. I would encourage you to have a look at it, and encourage you as the patients to get a copy in your A&E department or in your doctor's surgery, just to help the care team think about some of the rarer causes of these problems in thalassemia. Thank you very much indeed.
Thank you, John. Excellent. And it looks like an extremely useful resource, actually, which should be, as you say, on hand for all treating centres and patients. Okay, so I think we just have minutes left for some questions. All the speakers are available. Yes. Good. Hello, everyone. In fact, only a single question has come up on our system, but I have a couple of additional ones which I'd like to address. The question that was posted for Professor Capellini during her talk about thrombosis is from Maria Theophanous, and it's an interesting comment which says, I think doctors have to stop performing splenectomy. And I wondered if you'd like to comment on that.
Yeah, this is a good comment, more than a question. And actually, I have to say that the attitude to splenectomize thalassemia patients has changed significantly during the last 10 years. And there is a paper already published some years ago by Antonio Piga showing how the attitude to splenectomized patients, especially those transfusion dependent, is definitely less and less. And this is understandable, first of all, because with proper transfusion regimen starting early in life, we avoid to have huge spleen as we used to have in the past. Let me put the chart of my computer. Secondly, even in non-transfusion dependent patients or thalassemia intermedia, we were used to splenectomize patients hoping to increase the hemoglobin level. This is not always the case, and we try to approach the problem in a different way and try to preserve the spleen as much as possible. I can make a comment on partial splenectomy, which was implemented in some places. I personally am not in favor of that, and we are not doing it, but in some cases it has been done. Last, I add that for the future, probably with the novel therapy, splenectomy will be a very, very remote option.
Thank you. There's a question from Manal Zatar, which is for Professor Skordis. And it asks about the effect of taking hydroxyurea on infertility in males, if taking the medication before puberty. Is that something you could comment on?
Yes, the detrimental effects of hydroxyurea are known for spermatogenesis. It is one of the side effects, actually. If this is the answer, if this answers the question.
Professor
it's not
Porter, you're looking
recommended.
uncertain.
Yes,
Yes.
John, do you want to comment?
It's a common. Yes, thank you. Can you hear me? Can you hear me? Yeah. So
Yes.
it's
Yes.
a common issue that comes up in sickle cell disease as well. The general view is that long-term infertility from the use of hydroxyurea previously is not common, and we don't advise people trying to get their partner pregnant if they've had hydroxyurea in the last 6 months, but provided they have a good washout, it's generally not a problem. And in the sickle studies, many patients got their partners pregnant despite being on hydroxyurea unintentionally. So I think it can be a problem sometimes, but and we always we try to get sperm samples done before we start patients on treatment. What we actually find is that quite commonly patients are oligospermic or have problems, and we find that early. And it's very important not to attribute infertility problems to the use of hydroxyurea if you don't have baseline information. So we would want to get baseline, but we think the infertility effects of hydroxyurea have been exaggerated.
Thank you. I have a question for Professor Capellini also. You showed us some very interesting data about brain injury, and you mentioned that it was asymptomatic. I wonder, have there been studies of cognitive deficits, cognitive impairment in the people who were demonstrated to have brain injury? I can't hear you. I think you're maybe on mute.
Was I mute? Yes, thank you for the question. There are data, not only in patients who have brain damage, but if I remember correctly, and John may confirm it, there are also some studies proving that there is a cognitive, that's in sickle for sure, but also in thalassemia, a cognitive let's say not deficit but decline probably earlier than in a general population as expected. So this is something which need to be explored, and what can be the cause, either the cerebral flow, the silent thrombosis has to be explored. We are now doing some cerebrovascular evaluation in some of our thalassemia patients, especially those not transfused. We will have the results soon.
Thank you. There is a question that's in Greek, which was for Dr. Eleftheriou. I don't know, Perla, can you see the question screens? It's from Maria Theophanis.
I saw it and I answered.
Oh, you did already.
Sorry, yes, I saw that. I answered. Basically, the question is, basically the question was that, or it was a comment actually, that the doctors often react with suspicion. Patients report pain, and they're told that this is their imagination or something not, important enough to discuss or deal with. And I totally agreed. I said, yes, I agree that reports of pain by thalassemia patients are often underestimated and not taken seriously and prioritized less. And this is why I wanted actually to say, and this is a good opportunity, that I do propose that pain management and sort of assessing pain is incorporated into all our consultations, at least in the annual review, in the once a year, very detailed kind of consultation that should be taking place with the patients, because this is not part of it at the moment, and it's very hit and miss, and and this is the reason why it's underestimated and not dealt with.
Okay, thank you. We're running out of time. So just one final question, if I may, for Professor Skordis. You emphasize the importance in males of fertility induction when they're young, so in their perhaps early 20s. Is it now routine practice
Yes.
where you are, and I don't think it's in the UK, to screen all the young men to see what their sperm counts are at that stage and have the discussion to get onto treatment then? Because I don't think that yet standard intervention.
Well, theoretically, yes, it has to be as a routine to screen the males. We're talking about the normal males that they require no treatment. Otherwise, if the male has hypogonadism, then this is a must to check for spermatogenesis in their early 20s. And if so, this is the ideal age to induce spermatogenesis. Otherwise, then chances of achieving spermatogenesis later in life, they are limited. So the advice is that if the male has hypogonadism, then spermatogenesis has to be induced in their early 20s, save the sperm in the bank, and then use it for future pregnancy.
But not in all young men, you wouldn't recommend?
Yeah. The reason is that if a male has hypogonadism, the options of treatment is either testosterone, which is given every month or daily as a gel, or the combination treatment that involves 3 injections on a weekly basis. This is not convenient, and most of the patients, they don't follow this treatment. But this is a treatment for spermatogenesis. So once spermatogenesis is achieved, then they can continue with the treatment that is more convenient for them and more practical.
Okay, thank you. John, did you want to come back?
Yes, you pick up John, on the minutiae of my facial expressions. Yes. We've had several patients who we've had to induce spermatogenesis relatively late in their 30s because of gene therapy or other reasons, and actually we've had quite good success. I'm not. Yeah. I mean, I think the general point that the sooner you start thinking about these things, the better. I would agree with completely, but I don't think all is lost for a well-treated patient in their 30s who may be oligospermic. We've had some good success there.
Good, thank you. Well, that's an optimistic note on which to end. So we're now just a few minutes over, and I'd like to thank very much all the 5 speakers for excellent talks and for a quite short, but anyway, interesting debate at the end. Thank you.
Okay, thank you too.
Thank you, everyone.
Bye-bye.
Bye-bye.
Bye.